Good evening, everyone. Thank you for joining us for month number 2 of our Educate to Elevate series presented by Twin Cities Orthopedics and Training House. For those of you that may be unfamiliar, Twin Cities Orthopedics provides sports medicine services to various organizations across the metro through our certified athletic trainers and team physicians, while Training House is our sports performance and rehabilitation arm, serving partners throughout the metro and beyond through our sports performance coaches, physical therapists, sports dietitians, sports scientists, and several other providers. This evening, we will be discussing athletic injury basics. There will be a few interactive questions during the presentation, so please participate as you are able, using both the chat function and the polls that show up on screen. If you have questions, please submit them via the Q&A function or type them in the chat box as we go. Tonight, I have the pleasure of introducing Dr. Parker Hansen and Alyssa Tiedens for our session on athletic injury basics. Dr. Parker Hansen is a sports medicine fellowship-trained physician and will be leading the majority of our talk this evening. He completed his family medicine residency at the University of Wisconsin-Madison and his sports medicine fellowship at the University of Minnesota. Dr. Hansen currently sees patients at our Eden Prairie and Edina Crosstown locations. Alyssa Tiedens is a certified athletic trainer that has been with TCO for 6 years, previously as an athletic trainer at Bethel University. She received her bachelor's degree in athletic training from the University of Wisconsin-La Crosse and her master's degree from Portland State in community health and health studies. Her current role with TCO is serving as a sports medicine clinical navigator and concussion specialist. And with that, I am going to turn things over to Dr. Hansen.
All right. Thank you so much, David. And thank you guys for having me here for the Educate to Elevate talk. Again, I'm Parker Hansen. I'm one of the primary care sports medicine physicians at Twin Cities Orthopedics, practicing non-operative sports medicine. So figured we could do a little bit of learning tonight about the basics of some athletic injuries and how to get an idea of what's going on at home and when you need to be seen and when you can kind of manage things on your own. So objectives tonight, first thing I think in order to kind of understand some of these injuries, we have to go through some of the basic anatomy and figure out kind of how it relates to these different types of sports injuries. We'll learn a couple of the typical presentations for these common injuries. We'll discuss some of the home treatments that are generally safe to get started before you can seek care from a medical professional, and then understand when you need to see a medical professional, whether it's emergently or if you have a little time. So we'll kind of run through the chat here and see what kind of injuries people have had. I think a couple have already populated some sprains, ligament tears, some of the more common stuff, hamstring strain, tough soft tissue injuries, and a lot of what we'll focus on tonight. So brief anatomy lesson, bear with me, hopefully this won't be too boring, but I think it's important to understand. So especially when you're talking to a medical professional or medical provider about what's going on, understanding some of the terms they may use can give you a better understanding of what to expect in terms of the workup, recovery, and whether or not further intervention is needed. So the first thing I'd point out is some vocabulary. So the first word is ligament here. A ligament usually pertains to either a sprain or a complete tear. Rupture is another term that you'll hear used when people are discussing ligament injuries. And a ligament is a structure that connects bone to bone. The second vocabulary word here in anatomy lesson is tendon. Tendon is the structure that connects bone to muscle, and you'll hear terms such as tendonitis, which is common inflammation of this structure, typically from overuse. You can also hear the word strain, which would be related to the muscle portion of this structure, or tear. Again, a ligament connects bone to bone. A ligament is going to undergo a sprain or a tear. a tendon is going to tear or inflame, and a muscle is going to strain or tear. So we'll start out talking about sprains, probably the most common injury that we see. So a sprain is an incomplete injury to the ligament, which again is the bone-to-bone connection. This can occur at any joint or any articulation or connection between bone where there's a ligament holding those two bones together. Common signs you'll see: swelling, bruising. The reason you'll see bruising is that ligaments have a blood supply. They have blood vessels, small blood vessels within them. So anytime there's a tear or rupture, it'll cause some of that blood to go elsewhere. Times you definitely need to be seen in the office. So while it might end up being a sprain, you could be thinking about the damage to the structures that the ligament connects to, most namely the bone. So if you can't walk on it, if you can't move it, any type of tingling, or if you have significant changes in the skin color, not necessarily bruising, but more so if you lose color in the skin, if it becomes pale, dusky, or very red, warm, and hot. Times to be seen in the emergency department: basically, if you can't control your pain to a tolerable level with ice or over-the-counter medications, if you start to experience severe numbness where you're losing sensation throughout the entire limb, significant color changes, again, that dusky loss of color is indication that there might be some damage to the vasculature or the blood vessels in the area, or if there's a large deformity, which should indicate that there could be a significant fracture that may need surgical management. All right, then we go into full ligament tears. So this is these are types of injuries that always make people a little bit nervous. So these typically, again, occur at the joint. So they're connecting one bone to another. And so that's kind of the definition of a joint. Common signs: really hard to tell full tears versus sprains, but you'll see swelling and bruising. Being seen in the office, the exact same thing. It's very hard to tell a partial tear from a full tear without kind of seeing a provider. When to be seen in the emergency department, same thing. So to really kind of take a lot of me babbling at you and put it together, if one side looks totally different from the other side, if somebody can move the bones surrounding the injury a lot more than they can move the bones around on the other side, those are both indications of either full ligament tears or high-grade partial ligament tears, and should certainly be evaluated to see if you would benefit from further treatment. Fractures, everybody kind of knows about fractures. This is injury to a bone. It can occur at any bone in the body. Pain, swelling, deformity. A lot of times people will describe a broken bone as having a sound, but that's not always the case. And sometimes they'll describe it as a really severe burning sensation. And that comes from basically the nerves that are impacted by fractures. So these are things, if you think that you have broken something and one of our offices isn't available, it's always reasonable to be seen in the emergency department, because they can at least get some images and help you manage your pain until you can see somebody in our offices. All right, strains. So we're transitioning from ligaments and bones to tendons and muscles. So a strain can occur at any muscle in the body. Common signs: pain and spasm. So spasm, when I'm talking to somebody in the office, is usually described to me as like a grabbing sensation. So maybe you try to contract a muscle and move a certain way, and you feel a strong grabbing sensation, that is usually a muscle spasm. Muscle spasm uh, can be something that happens in isolation, where you've just injured the muscle or strained the muscle. But it can also be a sign of other injury to the tendon, the bone, or the ligaments below it. When to be seen in the office. I think the biggest one here is when we say can't move it. And what that means is if somebody asks you to move something and your brain is telling your body to try and move that uh try to move that extremity or move that part of your body, and you cannot not get that body part to move, that is something that needs to be seen, because that can be evidence of a full tendon rupture or a full tendon tear. So here's a picture of a Achilles tendon tear. It's one of the most common types of tears that we see, usually in a little bit older population, kind of mid 30s to mid 40s is the peak. This is the hallmark sign of a tendon rupture or a tendon tear, is that you can't do that voluntary movement. So that's really, I mean, the big thing is that if somebody can ask you to move something and you can do it comfortably or semi-comfortably, the chances of you having a full tendon rupture or a full tendon tear are pretty low. Now, I say that with the caveat being that we have lots of different muscles in our body that control the same movement. And so if you totally cannot make a movement, that is almost certainly a full tendon rupture tear, or a full tendon rupture or tear. If you can move it, but it's very, very weak, that could also mean that the other muscles that control similar movements or basically the same movement are trying to pick up the slack a little bit. But it's not going to be as strong because you're losing one of the muscles that's responsible. All right, flying through a little bit, but we'll touch on these quick common injuries. So if you don't remember like anything at all from this, which like you might always get what a ligament and a tendon are confused, or you might be like, if there's bruising, I'm not comfortable with it, I want to be seen. That's great. We're happy to see you and help you out. But this, I think, is something that is really, really useful, because this is one of the most common injuries we see. And it's a big reason why people end up in the emergency department when they could kind of be seen in our orthopedic urgent cares or by one of the providers at a more convenient time with less weight and less expense, really. So these are called the Ottawa ankle and foot rules. And what these are rules that say whether or not you need to get an x-ray for a foot injury or an ankle injury. So this is like kind of like, I rolled my ankle at the game tonight, like, do I need to go be seen? So these rules apply to any injury that occurs in within a week of the evaluation. So real quick, if everybody wants to feel their ankle, I'll point a couple of things out. So there's really kind of 4 spots that we care about in the ankle or the foot, that if you have an injury and you're sore there, you definitely need to go in and get an x-ray, either that night or the next day. The first 2 are what are called the malleolar zones. So if everybody feels on the inside and the outside of their ankle, they'll probably feel 2 big bony bumps. Those are what are called the malleoli. One of them is what's from the bone on the inside called the tibia. The other one is from the outside bone called the fibula. If you have pain on the back side of either of those large bony prominences up to 6 centimeters up your leg. So the back side of those towards your heel, those are places where that does not hurt with a typically does not hurt with a sprain. Those would be concerning for a fracture of some kind. So you should be seen if you have pain in either of those spots. The next one, so and those would be the ankle rules. Then we get to the foot area. The midfoot has two spots that we care about. One is called the navicular bone, which is on the inside. So again, if you go to the inside part of your ankle and feel that really prominent bone there, and then just slide forward towards your toes, you can feel another much smaller bump on kind of the inside part of your midfoot. That's your navicular bone. If you're tender there, that's a bone that doesn't really heal all that well if it is broken. And so if you have pain there, go in and get an x-ray. The last spot is what's called the base of the fifth metatarsal. So basically, if you go to the outside part of your ankle, feel that big prominence drop down into your heel and then walk your fingers towards your toes, you'll feel another kind of smaller bump on the outside part of the foot about midway between your heel and your toes. That's the base of the fifth metatarsal. That's also a place that if you have a broken bone there, you don't want to mess around with. So if you have pain in any of those four areas, come in, get an x-ray, do an x-ray that night or the next day. The other part is if you cannot walk at least 4 steps at the time of injury and say you're getting evaluated, then the next day or the next day, those are also reasons that you need an x-ray. So pain in any of these 4 locations or you can't walk, go be seen. The last one, this is just kind of a fun one. This is called a common injury from the result of a fall on an outstretched hand, which you could think of like tripping and putting both of your hands out and trying to protect your face from hitting the sidewalk. So that's falling on an outstretched hand. It's also called a Fuchs injury. One of the most common bones that is broken with a Fuchs injury is called the scaphoid bone. It is kind of, if you're looking at the top of your hand, it's on the thumb side of your wrist. And a place that you will have pain or would need an x-ray if you have pain is something called the anatomic snuff box. So if everybody like stretches out their fingers and tries to give like a big thumbs up, you can see a couple of tendons creating this kind of triangular spot down here by the thumb. That's called the anatomic snuff box. If you can press down on that and that's really painful after you've fallen on an outstretched hand, you need an x-ray. Treatment options, these are things that are safe to do no matter what the injury. So this is kind of immediately after stuff. Classic rest, ice, compression, elevation, getting it above the heart. Tylenol, maximum dosing, 1,000 milligrams 3 times a day for adults. Pediatrics, you should look at the bottle. Ibuprofen, maximum adult dosing is 400 to 600 milligrams 3 times a day. Usually tell people to take it with food, and don't take it if you have a history of kidney problems or if you've ever had any like bleeding ulcers or stomach problems. All right, so we have 2 questions and then I'm done. So let's see. Not sure how there we go. All right, so see if we can remember a brief part of that anatomy. So which best describes a sprain? I'll let you guys read that. And it doesn't let me vote, so. So we'll just kind of populate the answers. There we go. Okay, pretty good split here. All right, so we were very close. So a sprain, remember, is a injury to a ligament. You guys were both right. It's a partial tear, but a ligament connects bone to bone. So the top people took that one. It's the first answer, partial tear of a ligament that connects bone to bone. Can move on to the next one. Share that. Quick true false one. So see if this happens to you, what you guys would think. So does this scenario require an X-ray? Kind of a true false, so we'll give it maybe a minute. All right. Maybe we can see if what we got here. Yes. All right. Excellent. So the two parts of this that require the X-ray would be they cannot walk more than 4 steps in the office or at the field, and you guys were able to easily identify that having pain on the backside of the medial malleolus requires an X-ray. So good job, good troubleshooting, good triaging. You guys know exactly what to do. So happy to take any questions about anything I talked about tonight or sports medicine in general. So I'll stick around.
All right. So off of things that Parker, Dr. Hansen was just talking about, you notice some of the things and now you realize you need to be seen at TCO. So what are those next steps? So you have 2 options. You can schedule a visit with a physician. We have 35 locations across the metro and Western Wisconsin. And then we have our partner athletes and families that have access to our clinical navigators, which is what I do. Otherwise, you could go to an orthopedic urgent care, which we have open from 8 a.m. to 8 p.m., which is 7 days a week. And all of our locations can be found online at www.tcomn.com/OUC. So if you're working with our clinical navigator role, we have 2 clinical navigators that you may work with. I am one of them. Our role is to help partner athletes and their families navigate TCO following an injury. And some of those ways might be helping find the right physician for you and your condition. So we would help you find a convenient location for you, as well as figure out which doctor you need to see. Sometimes that could be a team physician or a physician who specializes in something that would be good for your unique injury. We can help expedite the process with priority scheduling, which exists with a backdoor access. Our partner athletes are able to get in a little bit sooner than you might expect, just with the relationships that we've built with some of our team physicians and our doctors. And then we also offer after hours and weekend scheduling assistance. So we understand that injuries can happen at not the most ideal times and some odd hours. And so we try to offer some assistance outside of your normal 9 to 5 to give you some direction of where to be seen and where to go. So when to contact your clinical navigator. It might be following an acute orthopedic injury that needs to be evaluated by a physician, just like Dr. Hansen just discussed. It might be when you have a chronic injury that needs further evaluation, maybe something that you've been kind of treating on your own and it's been kind of lingering and you think it's time to be seen. It might be when you just aren't sure what your next step should be. Maybe you don't know if the condition is treated by TCO, or you're not sure where to go with something. We would be a good resource to offer some options for you and give you some direction regarding whatever questions or conditions you might be experiencing. And then if you have any questions regarding TCO and the services we offer, TCO has grown a lot over the past few years. And so we've begun to offer other services outside of doctor's visits. So if you have any questions regarding any of that, our clinical navigators can be a good resource to give some direction on that as well. So how to contact our clinical navigator? There's a handful of ways. One of them, email at clinicalnavigator@tcomn.com. That email is sent to both me and Mairead, our other clinical navigator, and we would respond usually by phone or email if no contact information is provided. Some of our teams have our QR code where the athlete can take a picture of that code, and they're brought to a web page where they'll provide information regarding their injury, and that is sent to me and Mairead, and then we would respond accordingly to that. Otherwise, you can contact us by phone, which our phone numbers are listed there for you, and we'd be able to get you set up with your scheduling and any other needs that you might have with your injury. And then any questions for me or Dr. Hansen, we're happy to help.
Awesome. Thank you, guys. So feel free to drop questions either using the Q&A box or our chat function here. So looks like one question already came in, Dr. Hansen. So as a softball pitcher, what are some things that I can do to keep my arm healthy to prevent injury?
Yeah, great question. So one of the biggest things with throwers in general is that we see a lot of overuse injuries in this population. And so I think something to really keep track of is your pitch counts. The thing that I say to a lot of young throwing athletes is that you should definitely focus on quality over quantity. And so it really doesn't take 100 pitches to make a change. It can take 10 pitches with a specific type of focus and a specific type of feedback to make that same change. The other thing I would say is do not ignore pain. Do not ignore what some people would refer to as a dead arm. That is your body trying to tell you that something is wrong. And so I see a lot of people who talk about elbow soreness or shoulder soreness or wrist soreness, and they thought, well, I'm just gonna pitch or throw through this. But there is a reason that you're feeling discomfort, and I think getting on top of not only figuring out what is causing the discomfort, but how to appropriately rehab, or how to appropriately cross train, or how to train, or maybe even kind of changes in your throwing motion that are required to have longevity. So, and I work with a lot of college athletes, and it's incredible how that mindset changes from the time that they are freshmen to the time that they're seniors. I think a really kind of mature approach to sports as a young athlete is recognizing that there's things that you can do now to support your longevity as an athlete. And so even though you can pitch or throw through it, doesn't mean you should.
That's great. Kind of on that same realm, could you maybe touch on just generic things that athletes and families can do at home to help prevent injuries or mitigate injury risk?
Yeah, so a really good rule of thumb, especially for younger athletes, is that there's really good studies to suggest that you should not participate in any sport for more hours a week than you are years old. So if you're 12 years old, you should not be doing the same sport activity for more than 12 hours in a week. That can be a little bit controversial, but we have really good evidence to suggest that that type of volume is what's best. And so I really encourage families and athletes to focus on getting involved in a variety of different activities, cross training, getting involved in other sports. Almost every college athlete that I work with or professional athlete that I've worked with in the past was a multi-sport athlete. And so I think that, really trying to avoid sport specialization too early is a huge key and a huge decision that families have to make kind of early on, but it can really help prevent injuries.
Awesome. Another one that I've got for you guys that either Dr. Hansen or Alyssa, either of you could take, but what are maybe some things that you would recommend people don't come to our OUC for? Like, what would you recommend maybe you should go to the ER versus coming into an orthopedic urgent care?
I work some urgent care, so I might be able to tell you some things that I've had to turn away.
Sure.
So I think the first thing is any type of open injury. If there's any break in the skin, you're going to get sent to the emergency department. So even though it is, potentially a sports related injury, bypass the orthopedic urgent care because that's going to need some sort of surgical intervention. The other thing is that if there's concern for a secondary infection of any joint, so if your elbow is red hot and swollen and it hurts to move it, we treat that as an infection until proven otherwise, and that's something that requires really quick evaluation and should be seen in the emergency department. Other than that, I think the biggest thing is that if there is a large deformity, then those are things that could potentially also require surgical intervention and are maybe best seen kind of more emergently than otherwise. And then the last thing I would say is anything that indicates something that we call compartment syndrome, because that's a surgical emergency and you should look it up. But basically that's like a little bit of what I touched on. So if you have a pale extremity, or you don't have any pulses in the extremity, or the really the biggest one that we look for is, do people have really, really high levels of sensitivity? Like, can somebody just kind of gently rub their finger on the skin around the injury and it is extremely excruciating? That is something that is emergent.
I think one other thing I could add is from the athletic trainer side of things. For one, like if you need stitches, that's something that any urgent care won't really do for you. You'll probably end up needing the ER. And then the other thing that comes to mind is just in general, if you're feeling unstable, whether it's like you feel like you're going to pass out, or you feel like your pain is, like Dr. Hansen previously mentioned, is just so out of control that you could be at risk for maybe shock or something. That could be some other things that might be best to see the emergency room.
Awesome. Yeah, and we certainly don't want people spending a visit coming to see us if it's something that we don't typically see. So thank you both for your input on on those. One other thing that I had in my notes, Dr. Hansen, what would you say about the role of like growth plates as it relates to injuries for potential bony images? Would you recommend families do those sooner with growth plates being open, or could you maybe touch on the role of growth plates in those injuries?
Yeah, if you have a young athlete, and unfortunately there's no kind of like quick and easy way to say whether or not somebody's growth plates are open, but usually I say if you're somebody who's still having growth spurts, your growth plates are probably open. If you have concern for a fracture, that would raise my level of suspicion to get an x-ray, because there are certain types of breaks that can happen around a growth plate that can stunt growth and can lead to big discrepancies in the length of the bone that is injured in the future. So I definitely have a higher degree of suspicion and definitely pull the trigger on x-rays more often for younger kids, especially if they're what we would call skeletally immature.
Perfect. Awesome. Well, I'm not seeing any other questions coming in. So want to thank you, Dr. Hansen and Alyssa, for your guys' time this evening. I think it was a really good talk with some good discussion. So for those of you that are in attendance, if you didn't get a chance to jot down phone numbers or email addresses, I'm going to quick throw that back up on the screen for another second here. This information also will be live on our landing page that you use to register for the talk tonight. So keep an eye out for that. And, you know, we always hope that we don't cross paths from a sports medicine need standpoint, but if we do, we hope that you'll use the clinical navigator